Good afternoon, and welcome to the 2013 Robert S. Gordon Jr. Lecture on Epidemiology. My name is David Murray. I'm the Associate Director for Prevention and the Director of the Office of Disease Prevention here at NIH. I'd like to welcome everyone. Come on in, have a seat. The Office of Disease Prevention has sponsored this lecture each year since 1995, and I'm very pleased to represent Dr. Collins and introduce our speaker today. The Robert S. Gordon Jr. Lecture is awarded each year to a scientist who has made major contributions to research or training in the field of epidemiology or in the conduct of clinical trials. The Gordon Lecture Award recipient is selected based on recommendations from the NIH Epidemiology and Clinical Trials Interest Group. This is our 19th year that this award has been given, and if you look at the back of your program, you will see the list of prestigious scientists who have received this award previously. The Gordon Lecture was established in tribute to Dr. Gordon for his dedication to the field of epidemiology and his distinguished service to NIH. Over the course of 30 years, he served in numerous senior leadership positions, including Special Assistant to the Director and Chief Advisor for Clinical Practice and Research. Dr. Gordon was an early organizer of efforts to address the emerging problem of HIV and AIDS and became a key coordinator of AIDS research here at NIH. For the last 10 years of his life, Dr. Gordon made important contributions to NIH policy and management issues regarding epidemiology, clinical trials, and health effects of environmental hazards. This lecture is named in honor of Dr. Gordon's distinguished career and his many contributions to science. Now, it's a great pleasure for me to introduce a member of the NIH family, Dr. Mitchell Gail, as this year's Robert S. Gordon Jr. Lecture Award recipient. I'm particularly honored to make this introduction, as I have benefited personally from Dr. Gail's methods work and cite his papers often in my own research. Dr. Gail received his MD from Harvard Medical School in 1968 and his PhD in statistics from George Washington University in 1977. He joined the National Cancer Institute in 1969, where he served as chief of the biostatistics branch of the Division of Cancer Epidemiology and Genetics from 1994 to 2008. He continues as a senior investigator in that division. He is a fellow and former president of the American Statistical Association. He is an elected fellow in the American Association for the Advancement of Science, the American Society for Clinical Investigation, and the Institute of Medicine. He's received many awards, including the Public Health Service Distinguished Service Medal and the Nathan Mantle Lifetime Achievement Award for developing statistical methods for epidemiology. In 1989, he described a statistical model that now bears his name. The Gail model was the first cancer risk prediction model applicable to the general population. It has been used very widely to counsel and educate women about their risk for breast cancer. The Gail model provided the methodological foundation for the development of subsequent models that address a variety of other cancers, as well as for various populations, including minority populations. Dr. Gail is going to talk about his model for risk of breast cancer and discuss both the implications and the potential for incorporating additional risk factors to improve its performance. Please join me in welcoming the 2013 Robert S. Gordon Jr. Lecture Award recipient, Dr. Mitchell Gail. His presentation is entitled Using Risk Models for Breast Cancer Prevention. Dr. Gail.
Thanks a lot for the introduction, and thanks for coming. It's not easy to get in here sometimes, and certainly not easy to park. I really appreciate this opportunity to speak today, especially because I had the privilege of knowing Dr. Gordon. Dr. Gordon was instrumental in establishing the Society for Clinical Trials, and in 1982 he was the president of the Society for Clinical Trials. In those days, I was a young clinical trialist, and there was no textbook for how to set up a trial, how to conduct a trial, how to analyze a trial, and so it was very valuable to me to be able to go to the society meetings and learn from people who knew something about it. So it's a real pleasure to give this lecture in his honor. And I'd also like to acknowledge the intramural research program of NIH and the Division of Cancer Epidemiology and Genetics for continuous support of this research, and also for providing many collaborative opportunities that contributed to this work. So I'll be talking today about using risk models for cancer prevention. And I'll talk a little bit about what I'm talking about. That's absolute risk. What is it? I'll mention in review some of the risk factors for breast cancer. And then I'll talk about models that have been developing for projecting absolute risk and their applications, either in counseling individual patients or in cancer prevention in the general population. And one recurring theme will be how much do SNPs add in these applications. Now, here's a typical woman who might be coming for counseling. She's age 40. She began menstruating at age 14, which is what I call a baseline level of risk, the lowest level of risk for this factor. Early age at menarche increases the risk. She's nulliparous, which increases her risk compared to a woman who had breast cancer at an early age. She's had no biopsies, so that's a baseline or lowest level of risk. But her mother had breast cancer. That increases her risk. And we could ask, what is her risk relative to someone else, relative to a 40-year-old woman, all of whose risk factors were at the baseline or lowest levels? And of course, relative risk is useful in deciding which factors are important, but it doesn't really tell the woman what she needs to know, I think, about placing her risks in context. And here is the very same woman, but we ask a slightly different question, or really a very different question. We ask, what is the chance that this woman, she has all the same risk factors, what is the chance that this woman will be diagnosed with breast cancer by age 70 over a 30-year period? And according to this calculation, it is 11.6%, or 0.116. And this is a number that is not relative to someone else. It's her number, and she can use it to place that risk in context and begin to plan decisions about her life on that basis. And I'd like to just give a little more background about what the absolute risk that we just quoted is. Suppose a woman is well at age A, and she has a bunch of risk factors like the ones on the previous slide, X. And suppose she wants to know what's the chance she'll be diagnosed with breast cancer in a subsequent time period to age A plus tau. Well, a couple of things can happen. She might die of something else before she gets breast cancer, or she might be diagnosed with breast cancer during that interval. And absolute risk is the probability that she will be diagnosed with breast cancer in that interval, given that she is well at age A and has these risk factors X. Now, one thing that can decrease this absolute risk is an increased chance of dying of something else. So a woman at high risk of dying of something else will have a lower absolute risk of breast cancer. Certain things can increase the chance of being diagnosed with breast cancer. For example, if the interval is long, there's a larger chance of being diagnosed with breast cancer. If she has a lot of adverse risk factors, there's an increased chance of being diagnosed with breast cancer. And it tends to be the case that if the older the woman is, the higher her chance of getting breast cancer is, because the breast cancer incidence rate increases very rapidly with age. So that's the idea of absolute risk. And I'll talk about models that are used to estimate absolute risk, but before I do, I'd just like to remind you of some of the risk factors for breast cancer. And here are some that I call strong risk factors. You know, age itself is very strong. A 70 to 74-year-old woman has 56 times the risk of a 25 to 29-year-old woman. So age really has to be built into any model. If you have a major mutation in a BRCA1 or BRCA2 gene, if you're young, it can be maybe a 20-fold increased risk. If you're older, maybe a 2 to 4 increased relative risk there. If you've been radiated for Hodgkin lymphoma, let's say, in youth and received 40 gray, you have a 6-fold relative risk. If you've had a contralateral breast cancer, that really increases your risk, of course. Being born in a Western country is a major risk factor. Compared to rural China, the relative risk is 5. Mammographic density greater than 45% compared to less than 5%, relative risk of 4 approximately. So these are some major risk factors. And there are also some moderately strong risk factors. Family history is moderately strong. If you have 2 or more affected first-degree relatives, depending on the study, you can get relative risks in the range 2 to 5. 1, it's maybe 1.4 to 3. Having a biopsy is a moderately strong risk factor, especially if you have atypical hyperplasia. Hormone replacement therapy for a substantial duration is a moderately strong risk factor, and a delayed age at first live birth is a moderately strong risk factor. And then there are what I would call some weak risk factors, consistently demonstrated but weak. Age at menarche, if you have an early age at menarche, that increases your risk. A delayed age at menopause increases your risk. A BMI greater than 30, if you're postmenopausal, increases your risk somewhat, but if you're premenopausal, it decreases your risk. Drinking ethanol increases your risk slightly. And here's one. This is a SNP, a single nucleotide polymorphism in the fibroblast growth factor receptor 2. This is the strongest one that's been found for breast cancer, and one adverse allele increases your risk by a relative risk of 1.26. So if you have all these risk factors, you've got a lot of choices to make when you start trying to develop risk models. One of the choices is, should you make it primarily based on genetic theory, or should you take a more empirical approach? And we'll see examples of those 2 approaches. Of course, deciding what factors to go into the model is an important element. Should you have a very detailed family history or only some family history? How much of the reproductive history should you use? What about some of these medical history factors, not necessarily etiologic, but highly prognostic, like biopsies and mammographic density? In looking at the literature, it's important to keep in mind the data sources that were used to build the models and how they were pieced together. Some models are very coherent. They have a single cohort, and you can develop it that way. But many models pull in information from a variety of sources. And it's important also in looking at the various models to think about the target population that the investigators had in mind. Was it a general population like the UK or the US? Because the rates from the UK or the US might be embedded in those models. Or was the data primarily derived from a high-risk clinic? So the usefulness of these models will depend on all these factors. Here's some examples of genetically based models. Some of the first models were based on the assumption that breast cancer is an autosomal dominant disease. And a model that's pretty widely used, BRCA-Pro, allows you to use extensive family history based on this theory, and also to incorporate mutation data, if you have it, to project risk. And Elizabeth Klaus developed a similar model even before BRCA had been cloned. The BRCA genes had been cloned. But Elizabeth did a study herself that showed that really the familial aggregation patterns of breast cancer are not explained entirely by autosomal dominance. In fact, we know that the BRCA genes only account for perhaps 20% of the familial aggregation. So others have tried to expand on the autosomal dominant model by allowing for residual familial correlations above and beyond those ascribed to the dominant mutations. A nice model along this line is Bodicea, and another one is the IBIS model. And these references describe how this residual familial correlation is taken into account. One comment, these BRCA-Pro now, although not originally, and the Klaus model are models of absolute risk because they account for the possibility of dying of something else before breast cancer. These two models are models of pure cumulative risk, but they are larger than would be given if you accounted for the possibility of dying of some other cause. Now, this NCI's breast cancer risk assessment tool, or sometimes called the Gail model, is the model that I was describing on the first couple of slides. And just a little bit of history here. I started working in this area because I went to lunch with John Mulvihill, who was in DCEG many years ago in the mid-1980s. And he was counseling women about their breast cancer risk and actions that they might be inclined to take. And he found that many women had considerably overestimated their risk of breast cancer. And he wanted a more objective estimate of the breast cancer risk for these women. They were probably thinking autosomal dominant. My sister has breast cancer, therefore I have a 50% chance of having the gene, therefore I better have a mastectomy. So that was kind of a background for trying to be a little bit more data-driven in developing a model. And we used data from the Breast Cancer Detection Demonstration Project. A number of people in the division, including Louise Brinton, Kathy Shirer, and other people, Dave Byer, Sylvan Green, many people participated on this project. We derived the relative risk from the Breast Cancer Detection Demonstration Project and then reconstructed the BCDDP cohort data to get information on incidence and put it all together. Later, the incidence data from the BCDDP was replaced by SEER data, and that's what's today called the Breast Cancer Risk Assessment Tool, relative risk from the BCDDP, but SEER incidence data incorporated to turn these into absolute risk estimates. And they have the risk factors that I had mentioned previously. So that was that model, and I'll be referring to this model, BCRAT, in much of the talk. But no matter which model you come up with, it's important to try to validate the model before using it widely. And to validate a model, you should have independent cohort data because you need a cohort to estimate absolute risk and to test absolute risk. And I'll talk about calibration. Basically, does the model correctly predict the number of cancers that develop in the cohort over time and in subgroups of the cohort? Later, I'll talk about discriminatory accuracy, but I'll concentrate on calibration right now because several of the applications that I'm about to talk about depend mainly on calibration, not on discriminatory accuracy. And here was one of the first tests of the model. This model was used, the BCRT was used to design the breast cancer prevention trial. And Joe Costantino and co-workers used the control arm of that trial to see whether the predictions of numbers of cancers that later occurred in the trial were in agreement with what was expected based on the model. And you consider these 2,332 women who were age 49 or less. For each woman, a risk was calculated, and all those risks were summed up, and they added up to 55.9. So that was the expected number of cancers that we anticipated in that group. Actually, 60 were observed during the course of the trial, so E over O was 0.9. And likewise, for the other age groups, it was 1.1, 1.1, all close to 1, indicating good calibration. And overall, over the entire population, in fact, the E over O ratio was 1.0. So the model was well calibrated. And there have been a number of other tests of the calibration of this model, and it tends to do well. There was a recent paper, 2010, by Sarah Schoenfeld and co-workers, showing that there was a period before 2004 where the model somewhat underpredicted. So it's important to keep monitoring the models, monitoring national trends in order to make sure that the model stays in calibration, but it seems to be a well-calibrated model at the present time. Now, one thing you can do with a well-calibrated model is try to give a general perspective on risk when you're advising a woman about her options for disease prevention. And you can also use a well-calibrated model for a more formal weighing of risks and benefits. And I'll try to describe that in the next few slides. So a very contentious issue that came up not long ago. What should we do about women in their 40s? Should they have screening mammography? And in fact, the U.S. Preventive Service Task Force recommended against routine screening for women aged 40 to 49. They said no factors except age and deleterious mutations conveys a clinically important absolute increased risk for cancer. And the decision instead should be based on patient context, including the patient's values regarding specific benefits and harms. I agree with much of this statement except this part, because between age 40 and 50, the risk of breast cancer doubles. But there are many combinations of risk factors that can more than outweigh a doubling of risk from the age difference between age 40 and 50. So there may be many women in their 40s who might benefit from screening according to that logic. And here's an example. Suppose I have a 40-year-old woman. She's uncertain whether to have screening mammograms, but her mother and sister had breast cancer. Her absolute 5-year risk is 1.8%. And that's greater than that of a 50-year-old woman without risk factors, all of whose risk factors are at their lowest level, 0.6%. But according to those guidelines, the 50-year-old woman should get mammography. And if you carry the argument further, there's every reason to believe that this 40-year-old woman is going to benefit more than a 50-year-old woman who has no risk factors. So the point is that knowing your absolute risk can give you a certain context and an ability to think about problems, including perhaps whether you should have a mammogram. Is this an unusual circumstance? Well, Lindsay Wu and Barry Grobard, working with me, estimated the proportion of women in their 40s who have breast cancer risks as high or greater than a 50-year-old woman without risk factors. And let's just look at the dark lines here, which correspond to non-Hispanic white women. If that woman is 49 years old, over 90% of such women have a risk greater than that of the 50-year-old without risk factors. And on average, 74% of non-Hispanic white women have risks greater than the 50-year-old. And of non-Hispanic black women, the average is 31%. So there are actually between 11 and 12 million women with risks higher than a baseline risk 50-year-old woman. And they might well consider taking mammograms on the same logic that says that the risk-benefit ratio for mammography is good for the 50-year-old woman. Well, that was a kind of informal weighing of management style based on just knowing what your absolute risk is. Can we make a more formal argument for weighing risks and benefits? And this is work that was done on the basis of findings from the breast cancer prevention trial. And I'd like to just show how the weighing of risks and benefits depends on absolute risk, because absolute risk of each of the endpoints, each of the things that are affected by the intervention, is the common currency that it can be used to equate the various outcomes and come to some decision. So basically, Fisher et al. Published the key report on tamoxifen against placebo, and it showed that it reduced the risk of invasive breast cancer by nearly half, reduced hip fractures by nearly half, but it increased the risk of endometrial cancer, especially in older women. It increased the risk of stroke by 60%, increased pulmonary embolus threefold. And it had effect on, these were called life-threatening events. and we called these severe events. Again, it reduced the risk of in situ breast cancer by about 50%, but increased the risk of deep vein thrombosis by 60%. So how can a woman decide whether or not to take tamoxifen? Well, let's consider a 40-year-old white woman with a uterus who has a projected breast cancer risk of 2%. And what we do is ask her to consider what's going to happen to a population of 10,000 women just like her, and in the absence of tamoxifen, and also what would happen if tamoxifen were given to that population. Now, 200 of them, because of this 2%, we would expect to develop invasive breast cancer, 2 hip fractures, 10 endometrial cancers, 22 strokes, 7 pulmonary emboli. That's if we give no tamoxifen, and these are life-threatening events. If we give tamoxifen, we're going to prevent nearly half of those. We're going to prevent 97 of those 200 events, 1 of the 2 hip fractures. But unfortunately, we're going to cause 16 additional endometrial cancers. So instead of being 10, it would be 26 endometrial cancers. And we'll cause 13 additional strokes and 15 additional pulmonary emboli. Likewise, we can see what would happen for the severe events. We'll prevent 53 in situ breast cancers, but cause 15 additional deep vein thromboses. And some people think that all you should do is present data like this to the woman and let her look at the various types of outcomes and come to her own conclusion about what to do. But it may be helpful to her to sum these up and find out that there is a net 54 life-threatening events prevented and a net 38 severe events prevented in this 40-year-old woman in a similar population to her. So it looks like it might be something for her to strongly consider. And if you wanted to make one number out of it, you'd have to weight these differently. And suppose we give a weight of 1 to life-threatening and a weight of a half to severe. Then 54 plus half of 38 is 73 life-threatening equivalent events prevented by taking tamoxifen. So it seems like she might want to consider that. And if you're willing to adopt an index like that, there's that 73, you find that for young white women, there's a benefit of taking tamoxifen. If their invasive breast cancer risk is 2%, 4%, or 6%, the benefit increases with increasing breast cancer risk because you're preventing more breast cancer without incurring additional adverse events. But notice what happens for 50 to 59-year-old white women. If the risk is 2%, you actually have a negative benefit because strokes and endometrial cancers are becoming more dominant. So only the very high risk white woman in her 50s should consider taking tamoxifen. And you get a similar pattern for black women, but the benefits are a little bit less because the background stroke rates are higher. So some conclusions for tamoxifen. Young women at high risk stand to benefit the most. Women without a uterus have a more favorable risk-benefit ratio. I didn't show that, but I'll show it in a minute with other slides. And there's no single risk level like 1.67% that applies to all women. The decision really depends on the woman's age and her risk of these other outcomes, as well as her risk of breast cancer. So you have to weigh all of these possible outcomes in deciding what's good for the woman. Here's an extension of this work by Andy Friedman and colleagues in 2011 to older women, and using some slight changes in the background data, updated information on the things that went into the same sort of calculation. The sort of yellow pattern here corresponds to moderately strong evidence for a benefit, the blue to very strong evidence for a benefit. And you can see for tamoxifen, only women with very high 5-year risks, these are women with a uterus, stand to benefit. The gray means they don't benefit, it's a negative. Whereas for raloxifene, not only do you get a wider scope of young women in their 50s that benefit, but the benefits extend to older age groups too. And this is primarily because raloxifene does not have adverse effects of, on endometrial cancer risk, or very, very little. What if the woman does not have a uterus? Well, then the risk-benefit profiles for raloxifene and tamoxifen look rather similar. So there can be a role for tamoxifen, especially for the woman who's had a hysterectomy. Well, so far I've been talking about making individual decisions, trying to put your risk in context, and also making an actual treatment or intervention decision for the individual based on weighing her risks and benefits. Now I'd like to try to see what the implications of this kind of thinking are at the population level. And there are 4 important applications of risk models that I'd like to consider. One is designing prevention trials. One is assessing population absolute risk reduction from prevention strategies. And 2 others, and these 2 don't require a very discriminating model. But these last 2 points, the high-risk strategy for interventions that have adverse side effects and allocating prevention resources under cost constraints, they can benefit from a highly discriminating model, and I'll explain what that means in a little while. But before I get to designing prevention trials, I just want to say a word about assessing population absolute risk reduction from prevention strategies, because I'm not going to present slides on that. Suppose your risk model has modifiable risk factors, such as alcohol consumption, or level of exercise, or body mass index. You could ask, what's going to happen to the absolute risk in the population if you make favorable changes to those risk factor distributions, if you put everybody at the lowest level of risk factors for each of those? And I think this is very well worth doing, because you often hear the word attributable risk used for calculations of this type. And attributable risk is valuable, but it tells you what percentage of risk reduction there'll be. This tells you actually how much will the absolute risk be reduced. And it turns out that you can talk about a 20% attributable risk reduction, a reduction in risk by 20% that only amounts to an absolute risk reduction of 1 or 2% by the same interventions. So it's important to take this perspective in addition to the attributable risk perspective when you're looking about the potential value of prevention strategies. And Elisabetta Petracci, who is working in our group, did this using some Italian data published in JNCI. Well, let me turn now to these other 3 points. Designing prevention trials first. The power of a prevention trial to demonstrate that the intervention is really preventing disease depends primarily on the number of events observed, the number of breast cancers, if you're talking about tamoxifen trial, let's say. And the number of events observed is proportional to the average absolute risk of the trial participants. So using these absolute risk models, we're able to figure out how many events are likely to occur over the course of the trial, see how many women we therefore need to study and how long we need to study them in order to have a well-designed, powerful study. The absolute risk idea also has an impact on the eligibility criteria. The people designing the breast cancer prevention trial didn't want to include women in the study unless their breast cancer risk was high enough that they could probably benefit from tamoxifen, because they knew tamoxifen had some side effects. So they actually chose the average, 60-year-old woman, so a woman 60 years old or older would have a sufficiently high risk, they thought, to warrant entry into the trial, but they would allow younger women to enter the trial if they had the risk of an average 60-year-old woman, which turned out to be 1.67% in 5 years. So this is an ethical use of the risk model only to include people who stand to benefit from the intervention. Another impact of thinking this way, though, is that the trial has increased efficiency, because by including somewhat higher risk women, you're increasing the number of events that are likely to arise. You can get by with a smaller study and a shorter study. So these models were used in the design of the breast cancer prevention trial and the STAR trial of raloxifene versus tamoxifen. Now I'm going to turn to another topic, discriminatory accuracy. And this is really the ability of the model and the risk factors in the model to be very strong so that the people who actually get disease tend to have higher projected risks than the people who turn out not to get disease. And it's often measured by the area under the curve, it's so-called, the probability that a randomly selected case or person who develops disease will have a larger predicted risk than a randomly selected control. And here's an example. Suppose this is the two risk distributions here. These are frequency plots, and the red one is for cases, and the black one is for non-cases. If I take a random sample, one person from this population, and see whether that person's projected risk was higher than a randomly selected risk from a non-case. In other words, if I draw a random sample from this distribution, a random sample from this distribution, and see what's the probability that this absolute risk is bigger, it turns out to be 0.8. And that's the idea of this area under the curve. Ideally, our risk models would be discriminating enough that these curves would be completely separated, and we would know exactly who's going to develop disease and who wouldn't. But in fact, this would be considered pretty good performance. This, unfortunately, is what the breast cancer risk assessment tool sort of looks like. There's a lot of overlap between the distributions of risk in the people who turn out to develop disease and those who don't develop disease. The AUC is only 0.6, and that means it's got low discriminatory accuracy. We would like to improve that. We would like to get it up to 0.8 or 0.9. And one way to try to get it up to 0.8 or 0.9 is to include other risk factors, including SNPs, and we'll look at now to see what SNPs might be able to do for us. So can SNPs increase the discriminatory accuracy? And anyhow, regardless of whether they do or don't, do they have a big impact on certain public health applications? Now, the basic ideas that go into these calculations are described in a paper in Biostatistics in 2005 that talks about the importance of the risk distribution in the population. And once you know the risk distribution in the population, and if you know that the model is well calibrated, you can calculate all kinds of things like the area under the curve, expected losses in various public health applications. And I exploited these ideas to incorporate SNPs in papers in JNCI. Sholem Wacholder used an empirical approach in a paper in the New England Journal of Medicine to evaluate the improvement in predictive ability or discriminatory accuracy from incorporating SNPs. And in work with Juwan Park and Nilanjan Chatterjee, we've been trying to see what might happen in the future as we think about what SNPs might be discovered yet in the future. Here were 7 SNPs that were available in 2008. The strongest, notice the allele frequencies are pretty big because that's what can be detected by the usual designs for GWAS studies. The odds ratios per allele are pretty small. The geometric mean was 1.15. The strongest one was 1.26. So that means that if the person had 2 adverse alleles, it would be 1.26 squared, or 1.59 would be that person's risk compared to somebody who had no adverse alleles at that locus. And by getting various combinations of these, you might wonder, can we get a lot of increased discriminatory accuracy by incorporating SNPs in our models? And I'd like to just give you some feeling for that. This is a very revealing slide. But this is 7 SNPs. If we have 11 SNPs, which came along a little bit later, we got it up to 0.585. With 18 SNPs, we got it up to 0.587. Notice that the improvement is diminishing a little bit because the SNPs that get added later were harder to find. They tended to have smaller odds ratios per allele. But if we do a really huge job of compiling 3 times the number of cases and controls that have ever been compiled up to this present time for studying breast cancer, the work of Dr. Park, Dr. Chatterjee, and suggests that we'll get up to 70 SNPs. And in fact, we'll be able to get an AUC of 0.635, which is something of an improvement, and it begins to be an interesting number. Just to put it into context, the breast cancer risk assessment tool might have 0.607. You just have to ask 4 questions to get that. If you added 7 SNPs, you get it to 0.632. If you added 11, 0.637, not much, but we think that you could get it up to 0.67 if you added all the foreseeable SNPs. And those foreseeable SNPs may not be quite as far off as we had imagined when we did the calculations originally. The breast cancer risk assessment tool plus mammographic density will get you to 0.65, so that's a nice strong risk factor. Maybe combining density with foreseeable SNPs, we could get up toward 0.7. So we're starting to make some progress, but it's slow. Well, now I'm going to talk about 2 applications that require high discriminatory accuracy. One is the so-called high-risk strategy for prevention, when the intervention has adverse side effects. And later I'll talk about allocation of preventive resources. Both of these require good discriminatory accuracy. So what do I mean by the population strategy and the high-risk strategy? A good place to find out about this is the book called The Strategy of Preventive Medicine by Jeffrey Rose. And he talks about the population strategy. That is, suppose I have an intervention that is very safe and I can give it to everyone in the population without risk. For example, suppose I could suggest to people to eat less salt every day. And if everyone in the population lowered their blood pressure by 1 or 2 millimeters of mercury, that would have more effect on the number of heart attacks in the population than if I could find the few people in the population with very high blood pressure and go out and treat them. So if you can use a population-level strategy, it's very valuable to consider that option. But on the other hand, you may be forced into treating only people at high risk. And what would cause you to do that? Well, there are 2 considerations. One might be that the intervention has adverse effects, so you don't want to give it to people unless they have a high enough risk of the disease of interest that your benefit is going to outweigh the losses there. Another possible motivation for a high-risk strategy is economic. For example, in giving MRI exams, there's a current recommendation only to give it to people with high lifetime risks. You may not have enough money to give the intervention to everyone, so why not give it to the people at highest risk who need it the most? Well, let's go back to tamoxifen again and see whether this high-risk strategy works. Now, I've changed it. I'm now talking about 100,000 women. They do have a uterus, each of them. And they're in the age range 50 to 59, which we remember for tamoxifen is not such a good age range to be in. In 1 year, we would expect 246 of them to develop invasive breast cancer, 101 hip fractures, and so forth, summing up to 589.6 life-threatening events. If we give tamoxifen to everyone, the population strategy, well, we're going to prevent a lot of breast cancer and hip fractures, but because of the other serious events, we're going to end up much worse off. So we can't use a general population strategy. We have to be more tailored in giving the drug. And in fact, turns out that it's only beneficial for women with very high breast cancer risks, 774 per 100,000 per year in the 50 to 59 year age range. Only about 1% of the population has a risk this size, so that you're going to be focusing your intervention on only 1% of the population. Since a lot of the breast cancer is going to develop in the other 99%, unless you have an extremely discriminating model, you have limited potential for prevention here. And let me just show you how limited. Here's, again, if none get tamoxifen, there'll be 589.6 events. If you use a breast cancer risk assessment tool and just give the tamoxifen to those with a high enough breast cancer to justify it, you'll prevent only 1.4 events in 100,000 women in a year. Not very impressive. If you add the SNPs, it's 1.8 per year. Again, not very impressive. If we had a perfectly discriminating risk model, it would just pick out the 246 women who are going to get the breast cancer. You would treat them, and because you're treating so few, there would be very few adverse events, and you'd get a nice savings of about 119 or 120 life-threatening events. So if you had a perfectly discriminating model, you could do well. Now, remember, this is 1.4 we prevented so far. I'm going to make a comment on that in the next slide, in this slide. How could we do better with a high-risk strategy? Well, one thing is to make the intervention less toxic, because then you can give it to more people. And you remember those pictures about raloxifene. A lot of those, it turns out raloxifene's a lot less toxic because of it doesn't have any endometrial cancer risk. Maybe 45% of the population could get it. And if you do the similar calculations for raloxifene, instead of preventing 1.4 events, you might be able to prevent 20 events. So make the intervention less toxic, make it more effective in preventing breast cancer. That's a possibility. Improve the discriminatory accuracy of the breast cancer risk model. That's a possibility, but it's a long slog to try to do that, as I've tried to indicate on some of these slides. But I think we're making some progress. Another thing one could do is have more refined modeling of the risks of the other outcomes. If we have a good risk model for stroke and a good risk model for breast cancer, we can be more accurate in deciding who should get the treatment because we know more about the stroke risk. And so there is some promise there. But basically, I think if we could move toward less toxic agents, that would be the best way forward. Now I'd like to talk about one other application that also requires good discriminatory accuracy of the model, and that is allocating scarce preventive resources. So, in fact, let's suppose that we only have enough money to give mammograms to half the population. How would we do that? Well, one thing we could do is just give the mammograms at random. And these women here are shown in conjunction with rectangles. The rectangles are the actual absolute risk of breast cancer of the women. But if we give them at random, we don't even have to do a risk assessment. We just randomly assign them. And you see that some low-risk women get the mammograms, a high-risk woman gets the mammograms, and some intermediate. We expect to prevent about half the deaths using this strategy as we would if we could give the mammograms to everyone. Now, suppose instead we do a risk assessment on everyone, and then we only give the mammograms to those at highest risk. Are we going to prevent more death? Notice that in this picture, 4 people got the mammograms. In this picture, 5 people in pink got the mammograms. And that's because we spent some money doing risk assessments on the entire population and finding the ones at highest risk to give it to. If it costs too much to do the risk assessment, you're not going to have any money left for mammograms. So you have to be careful there, and that's an important ratio, the ratio of the cost of the risk assessment to the cost of the intervention. And I assumed that it was 0.02, 2%, because in other words, answering a questionnaire versus getting a mammogram read. Now, suppose everybody could get a mammogram, then we would get 100% of the benefit. People think that you prevent about 15% of deaths, whether in young women or older women, by giving mammograms. So you get 100% of that benefit if you could give everybody a mammogram. If you give the mammograms at random, and you only have enough to give half, well, you're going to only get 50% of that benefit. But if you rank them and use the breast cancer risk assessment tool to rank them, you'll now get 63%. That's an improvement. If you use the SNPs too, and we can do better than this, you're up to 66%, 67%, you're seeing that you can save more lives if you use this ranking type strategy, assuming that it's feasible to do. One thing about this, it may be something of an overestimate because it costs some money to draw the bloods, to assess the SNPs, and to transfer that information back. If this were all free, or if this cost just as much as this, 2% of the cost of a mammogram, these numbers would be valid. But if the ranking procedure costs as much as 20% of the cost of the intervention, then it's useless. So I've tried to talk a little bit about what absolute risks are, and a little bit about the models that have been developed to compute absolute risk for breast cancer. I've tried to discuss counseling patients, how knowing an absolute risk can give a general perspective that is useful in thinking about management, and how it can be used more formally to weigh favorable and unfavorable effects of a preventive intervention. I've tried to indicate that absolute risk is useful in designing prevention trials and can give a useful perspective on the risk reduction that you're really going to achieve potentially in the population if you had certain preventive interventions. All these applications only require modest discriminatory accuracy, but for implementing a high-risk prevention strategy or for allocating scarce resources, it's important to try to improve that discriminatory accuracy, and we're making some progress. If we get 70 good SNPs and mammographic density incorporated into the model, and if we find some other strong imaging or other factors that we can put into the model, we can do better in these areas. And I've indicated on this slide some of the people who contributed to work directly presented in this talk today. There are others that I've enjoyed working with that are not on the slide and are doing related things. So with that, I'd thank you and be happy to answer questions. Yeah.
The early slide you had there, the relative risk for a woman, I think 70, 74 was 56 times for a younger woman. That relative risk, is that over the lifetime, per year, per 5 years? What's
That's the instantaneous risk. It's basically the SEER rate for the 70 to 74-year-old woman divided by the SEER rate for the younger woman. And so it's instantaneously, in the next year, it's like a derivative, sort of. Mm-hmm. Yeah.
That was a wonderful talk. Thank you. It was really showed us kind of the power of the approach. And I wanted to ask you what you thought about two possible extensions of it. As you mentioned, for something like mammography, kind of in theory, you could be always updating the model. You could have a mammogram, and then depending on the results, you could do it. So it will become less and less expensive, presumably, to be rapidly sort of updating these risks in real time, maybe in ordinary practice. So I was curious whether you think that will be something that actually translates to meaningful benefit. And then the other thing is, you mentioned some risk factors that are behavioral, but it would be great if we could just say get your BMI down, but we don't know that you can. But we probably, again, increasingly are getting information so that you might be able to say, here's your risk, and we do know something about what happens when people attempt to, let's say, lose weight or reduce alcohol or whatever you speak about. You could presumably feature that in too. So you could say, there's a kind of a broader set of predictions. I'll predict the likelihood that you're going to get breast cancer in 5 years, and then I'm going to tell you a bit about how likely you might be to succeed if you were to attempt to change, X, Y, or Z. So both of those assume, and I think it's right, that the computing power will just get more and more so. but that struck me that they could be distracting and yet potential extensions of the general method. So I was wondering whether you thought that either of those would be kind of valuable directions to go, or just sort of finessing and adding useless stuff.
I'm going to make sure I understand the first part. It was about incorporating new risk factors like mammographic density as the data become available. Is that right?
In real time.
Yeah.
I get my mammogram, I come back and you say your number just changed.
Now, I think that there have been enough studies on mammographic density now that we know that it's a valuable risk factor. It really should be incorporated into models. One nice thing about the breast cancer risk assessment tool, you just ask 4 questions or so and you're done. As soon as you begin to use more informative data of the mammographic density type, it's a more elaborate process, but that's no reason why we shouldn't try to incorporate that information. Now, there's a long road between the idea and the quality-controlled implementation. And for example, how should we measure mammographic density? Should we use BCRAT? Should we use some automated procedure? If we need to get agreement on that, and then we can recommend a model that uses an agreed-upon way of measuring it. And then, ideally, before broadcasting it beyond the research setting, we should also try to do some independent validation in independent cohorts. So it's ready. I think that it's ready to introduce, but there are some steps that would ideally be done before it is made widely available. For example, Jimbo Chen in our group did some work on incorporating mammographic density, but the measurement used was a hand-driven planimetry, and it's not something that could be widely and generally used. So now BCRAT has shown a lot of promise, and it is being widely used. I think it's got good information there. Maybe we should go with something like that, but I think there's more information that could be extracted in a standardized way. The behavioral one is, I think that these models give you perspective on what would happen if, and it's a big if, what would happen if the people actually did implement the intervention? What would happen if what we've observed in observational data on these associations translates into the effect of an intervention? Because an observational association is not the same as an intervention. And so the issue is, now, I'm not saying, I think it can tell you what we potentially might hope to achieve, but I don't think it can tell you what we will achieve.
Thank you.
Yeah.
Thank you.
So with respect to discriminatory power of your model and how much it can go up, given that whole genome sequencing is becoming cheaper and cheaper, I was wondering if there might be a time that you do whole genome sequencing for a person for only, let's say, $1,000, and the information would be useful not only for predicting breast cancer, for everything else, and that's what you do one time in your life. Is it possible to predict, assuming we do a whole genome scan, and that we find variants that are not common, but increase the risk quite a bit, let's say relatively high relative risk, but uncommon mutations? Can we predict using heritability how much your model can predict that one person will have the disease or not, assuming that we have a whole genome sequencing from one person?
Now, my experience is really with SNPs, and I think we have a pretty good grasp on where we're likely to be able to get with SNPs. But as to whole genome sequencing, I've read one paper by some co-authors of Bert Fogelstein, based on twin studies, that try to say, since a twin is genome identical, we can try to use this information to figure out what we could possibly get if we were doing the whole genome sequencing. My recollection is that the results were not astounding, and this was published in Translational Medicine or something like that. But I think there probably are other people in the audience who might have more insight into what we might achieve. One limitation is clear. We had a hard enough time trying to extract the information on SNPs, and we were using larger and larger samples to do this. The multiplicity problems of whole genome sequencing are going to be that much greater. And so to fully extract the information, especially if you have many, many small effects, may take unimaginable or even unattainable sample sizes.
And my second question is, assuming we use your model to offer, let's say, mammography to 63% of the population rather than 50%, if the full benefit of the model is used, how likely is it going to be used to do that in the United States, where there are many different insurance companies and there are lots of lawsuits? If somebody, you tell them, no, this is not for you, and then in 1 year they get cancer. It might be very different in a country like UK, when there's national health system that offers it and they can basically triage people, versus the US that, there are different people. I'm not sure.
You're talking about the resource allocation issue?
Exactly.
Yeah, there are some assumptions there. And one of the assumptions is that the people who come to have their risk assessed are a random sample of the general population. Another assumption is that you can actually implement the risk-based allocation. And I'm just trying to show what could be done, not necessarily, and I think that one has to think very carefully before trying to do something like this in the particular context.
So, talking about the chemoprevention effect trade-off between risk and benefits, like the tamoxifen, my understanding was that we are considering all the life-threatening outcomes equal. So, has there been any attempts in, kind of incorporating more information like survival or how much cost they impose? So stroke might not, although stroke and breast cancer are both life-threatening, but they might not have the same value, the same weight in the cost they impose or their survival. So has there been any effort in this regard, and do you think it's a worthwhile consideration extension to the...
Well, we thought about doing that originally, and we decided that it would be better to try to keep it simple. But mathematically, there is no problem in assigning different positive weights to the outcome. And in fact, if you wanted to do this in an interactive mode, it might be important to allow the woman to assign her own weights, because she may not care about some of the things that you mentioned, but she may be deathly afraid of a stroke. And she would do anything to avoid a stroke. So she might give that a weight of 10. I think that things like that can be done by incorporating them in an interactive program. Mm-hmm. Yeah.
So